My name is Dr. Isabella Herman. I'm a pediatric neurologist and neurogeneticist. I'm currently based in Omaha, Nebraska at Boys Town National Research Hospital, where I'm the director of clinical neurogenetics and the neurogenetics program. The vast majority of my practice currently lies within neurogenetic conditions. And of that, at least half of the neurogenetic conditions that I see are genetic epilepsies, as well as, autism, other neurodevelopmental conditions, developmental regression. In epilepsy, gene testing increasingly informs nearly every aspect of care. From a diagnostic standpoint, it provides closure and prevents years of inconclusive tests. From a therapeutic perspective, results often drive immediate clinical changes. Some examples include the ketogenic diet in GLUT1 deficiency, avoidance of sodium channel blockers in SCN1A-related Dravet syndrome, or mTOR inhibitors in tuberous sclerosis. Prognostically, families gain clarity on seizure trajectory, developmental outlook, and even SUDEP risk in some epilepsy syndromes. Genetic results also guide surveillance for non-neurologic comorbidities like renal imaging in tuberous sclerosis or cardiac monitoring in channelopathies. A particularly striking example is CLN2 Batten disease, where genetic confirmation is essential to diagnose the condition and initiate Brineura, which is an intraventricular enzyme replacement therapy that slows neurodegeneration. In today's times, without genetic testing, that opportunity would be missed. Last but not least, gene results support counseling, reproductive planning, and clinical trial enrollment. In short, genetic testing moves epilepsy care from trial and error to precision medicine. When families finally get a genetic diagnosis, the benefits are transformative. Clinically, it helps avoid harmful drugs and guides more effective therapy, like steering away from sodium channel blockers in SCN1A or prescribing the ketogenic diet in SLC2A1. Prognostically, families gain realistic sense of seizure control and developmental outcomes. Counseling becomes accurate, recurrence risks can be explained, carrier testing offered, and reproductive options provided. Psychologically and psychosocially, families can connect with condition-specific support groups and advocacy organizations, meet other patients with the same condition. Importantly, diagnosis provides access to approved targeted therapies where they exist. Without genetic confirmation, patients with certain diseases would miss out on life-changing, treatments and precision medicine. And for conditions without approved therapies, a genetic answer opens up doors to precision medicine trials. So the benefit is not only theoretical of genetic testing and genetic causes, it has direct and sometimes life-saving consequences. Genetic testing and genetic diagnoses offer opportunities that would otherwise not be available for patients. The field of precision medicine in epilepsy is rapidly advancing. A genetic diagnosis transforms care from generalized to individualized. For example, SCN1A-related Dravet syndrome requires avoidance of sodium channel blockers and often benefits from other medications such as clobazam, stiripentol, cannabidiol, and ongoing antisense oligonucleotide trials. SCL2A1-related GLUT1 deficiency responds to the ketogenic diet. mTORopathies, including tuberous sclerosis and DEP-DC5-related epilepsies, benefit from mTOR inhibitors like everolimus. KCNT1-related epilepsy has investigational treatment with quinidine, while SCN2A gain-of-function variants respond to sodium channel blockers. One of the strongest cases for genetic diagnosis currently in the field of pediatric neurology and neurogenetics is CLN2 Batten disease, where Brineura, which is an enzyme replacement therapy delivered intraventricularly every 2 weeks, is FDA approved to slow disease progression. Without genetic testing, patients wouldn't qualify for these types of treatments. This illustrates the broader principle. Genetic diagnoses don't just explain seizures, but they unlock disease-modifying therapies and access to trial and precision medicine. Exome and genome sequencing have revolutionized epilepsy diagnostics. Unlike small panels, they offer unbiased detection of both known and novel genes, and genome sequencing adds detection of structural and non-coding changes. Studies show yields up to 50% in early onset drug-resistant epilepsy. Importantly, results can be reanalyzed as science advances, so value of exome and genome sequencing grows over time. Clinically, sequencing not only clarifies diagnoses but changes management, as seen in SCL2A1, SCN1A, and mTORopathies. And some diagnoses open the door to approved therapies. That's a striking demonstration of how sequencing can transform care, not only for diagnosis, but for therapeutic eligibility. Sequencing shortens the diagnostic odyssey, prevents unnecessary tests, and directly connects patients to precision therapies when available. Is a symptom of many different diseases, and identifying the underlying cause is critical for tailored management. It allows us to choose effective treatments, avoiding sodium channel blockers in Dravet syndrome, using ketogenic diet and GLUT1 or mTOR inhibitors in tuberous sclerosis. It clarifies prognosis and developmental trajectory. It enables surveillance for comorbidities, for example, renal tumors in TSC, cardiac arrhythmias in SCN5A disorders. It allows accurate genetic counseling and reproductive planning. Importantly, some causes have disease-modifying therapies available. A prime example of disease-modifying therapy is Batten disease due to CLN2 deficiency, where Brineura enzyme replacement therapy slows progression of seizures, motor decline, and cognitive regression. This therapy can only be accessed once the underlying genetic cause is identified. Therefore, determining etiology doesn't just satisfy curiosity. It can be life-saving, life-altering, and essential for delivering the right treatment at the right time. Although we traditionally think of genetic epilepsies as pediatric conditions, we now recognize a number of important adult-onset genetic epilepsies. Some of the most well-characterized adult-onset genetic epilepsies involve the mTOR pathway, particularly DEP-DC5 and related GATA1 complex genes, which cause familial focal epilepsy that often manifests in adulthood. In addition, somatic mutations in genes like mTOR or SCL35A2 restricted to brain tissue are increasingly identified in adults with focal cortical dysplasia undergoing epilepsy surgery. Certain sodium channelopathies, such as SCN8A and occasionally SCN2A, can also present with seizures in adolescence or adulthood. Beyond these, there are familial epilepsy syndromes like LGI1 or PRRT2 and progressive myoclonic epilepsies such as Unverricht-Lundborg disease or Lafora disease, which may first come to attention later in life. We also see mitochondrial disorders, including POLG-related epilepsy, and even late diagnosed neurodegenerative conditions, such as certain forms of Batten disease, where genetic confirmation is critical for access to precision therapies. Taken together, these examples highlight that genetics is not limited to children. In adults with otherwise unexplained epilepsy, genetic testing can provide answers, guide treatment, and connect patients to emerging targeted therapies. There is robust evidence that epilepsy shares a genetic basis with neurodevelopmental and psychiatric disorders. For example, SCN1A and SCN2A mutations link epilepsy with autism, while STXBP1 and SHANK3 link seizures with intellectual disability, autism, and psychiatric illnesses. mTOR pathway genes connect epilepsy with autism, ADHD, and tumor predisposition. Genome-wide studies have shown polygenic overlap between epilepsy and depression or schizophrenia. This explains why comorbidities are common and predictable, not coincidental in epilepsy. Clinically, this knowledge drives proactive screening and multidisciplinary care. Genetic testing can help explain multi-system presentations of certain conditions and directs families to targeted treatments. These examples highlight how genetic research doesn't just explain seizures, it helps explain whole phenotypes and guide comprehensive management. One of the things that is important to discuss is the recommendation of when genetic testing is offered for patients. Nowadays, there are recommendations where if you have children with first-time unprovoked seizures, the families should be offered genetic testing. This allows to decrease the time to diagnostic odyssey. We do know that if seizures are otherwise unprovoked, there's often, especially in early childhood, a genetic predisposition. So in my clinic, we emphasize the importance of genetic testing early on. And the newer generation of, clinicians are becoming more and more familiar to offering genetic testing early on. This is a striking difference compared to what happened several years ago, where genetic testing was often delayed due to either cost or inexperience by the clinician or just unavailability.